Yeah, hi everyone. Good evening, good afternoon, good morning, depending in which part of the world you are. My name is Dr. WAN, and today I will talk about refeeding syndrome in relation to our lifestyle. That is what we give to our loved ones when they get home from hospital. That will be our topic for today. And I strongly recommend medical students to follow up this lecture because it is part of their training. Do not forget to subscribe to my YouTube channel for more information and also how you will be notified for new videos coming up for you to follow up, kind of an update. And also do not forget to make comments with regards to what I'm about to lecture. So let's go. Refeeding syndrome is a well described but often forgotten condition. No randomized controlled trials of treatment have been published, although there are guidelines that use best available evidence for managing the condition. In 2006, a guideline was published by the National Institute for Health and Clinical Excellence called NICE in England and Wales. So essentially, we are going to use this guideline put in place by this British organization, a renowned institution, in order for you to understand what I'm here to say. So, why use the NICE guidelines on refeeding syndrome? That's the question. The guidelines are the most recent comprehensive review of the literature on refeeding syndrome. The guideline developed group was strongly multidisciplinary with wide-ranging consultation with both professional and patient stakeholders. The guidelines clearly identified points of good practice and areas of further research. The new guidelines give explicit clinical criteria for patients at risk and highly at risk of developing refeeding syndrome, enabling better identification and prevention. For patients with electrolyte deficits, the new guidelines recommend immediate start of nutritional support at a lower rate rather than waiting till the electrolyte imbalance has been corrected, as was recommended by previous guidelines, thus potentially avoiding further nutritional deterioration in patients. So here we go now with the question. So what is refeeding syndrome? That's the question. Refeeding syndrome can be defined as the potentially fatal shift in fluid and electrolytes that may occur in malnourished patients receiving artificial refeeding, whether enterally or parenterally. These shifts result from hormonal and metabolic changes and may cause serious clinical complications. The hallmark biochemical features of refeeding syndrome is hypophosphatemia. However, the syndrome is complex and may also feature abnormal sodium and fluid balance, changes in glucose, protein, and fat metabolism, thiamine deficiency, hypokalemia, and hypomagnesemia. Now, how common is refeeding syndrome? That's another question. The true incidence of refeeding syndrome is unknown, partly owing to lack of a universally accepted definition. In a study of 10,179 hospitalized patients, the incidence of severe hypophosphatemia was 0.43%, with malnutrition being one of the strongest risk factors. Studies report a 100% incidence of hypophosphatemia in patients receiving total parenteral nutrition solutions that do not contain phosphorus. When solutions containing phosphate are used, the incidence can decrease to 18%. So having said that, we now look at how does refeeding syndrome develop. So there are stages here. So we start looking at prolonged fasting. So under prolonged fasting, we have the underlying causative factor of refeeding syndrome is the metabolic and hormonal changes caused by rapid refeeding, whether enteral or parenteral. The net result of metabolic and hormonal changes in early starvation is that the body switches from using carbohydrate to using fat and protein as the main source of energy, and the basal metabolic rate decreases by as much as 20 to 25%. During prolonged fasting, hormonal and metabolic changes are aimed at preventing protein and muscle breakdown. Muscles and other tissues decrease their use of ketones body and use fatty acids as the main energy source. This results in an increase in blood level of ketones body, stimulating the brain to switch from glucose to ketone body as it maintains energy source. The liver decreases its rate of gluconeogenesis, thus preserving muscle protein. During the period of prolonged starvation, several intracellular minerals become severely depleted. However, serum concentrations of these minerals, including phosphate, may retain normal. This is because these minerals are mainly in the intracellular compartment, which contracts during starvation. In addition, there is a reduction in renal excretion. Now, during refeeding, glycemia leads to increased insulin and decreased secretion of glucagon. Insulin stimulates glucagon, fat, and protein synthesis. This process requires minerals such as phosphate and magnesium and cofactors such as thiamine. Insulin stimulates the absorption of potassium into the cells through the sodium-potassium ATPase symphotor, which also transports glucose into the cell. Magnesium and phosphate are also taken up in the cells. Water flows by osmosis. These processes result in a decrease in serum levels of phosphate, potassium, and magnesium, all of which are already depleted. The clinical features of the refeeding syndrome occurs as a result of the functional deficits of these electrolytes and the rapid change in basal metabolic rate. Another question: what electrolytes and minerals are involved in the pathogenesis? So we have phosphorus. Phosphorus is predominantly an intracellular mineral. It is also for all intracellular processes and for structural integrity of cell membranes. In addition, many enzymes and second messengers are activated by phosphate binding. Importantly, it is also required for energy storage in the form of adenosine triphosphate, known as ATP. That's a kind of energy that's being released. That's the meaning here. It regulates the affinity of hemoglobin for oxygen and thus regulates oxygen delivery to tissues. It is also important in the renal acid-base buffer system. Now, the other component that we have to look into it is potassium. Potassium, the major intracellular cation, is also depleted in undernutrition. Again, serum concentration may remain normal. With the change to anabolism on refeeding, potassium is taken up into cells as they increase in volume and number and as a direct result of insulin secretion. This results in severe hypokalemia. This causes derangements in the electrochemical membrane potential, resulting in, for example, arrhythmias and cardiac arrest. So you can see what happens when someone returns from the hospital after a long period of inconvalescence. So that's what could likely happen when you put them on heavy meal, like our popular food you call Khati-khati, or some of the meal that we have at home. We don't really have to put them right away into such short diet or call it traditional diet, but try to look for something which is mild, less aggressive, and also permit the stomach to absorb. Now, the other component here, it is magnesium. Magnesium, another predominantly intracellular cation, is an important cofactor in most enzyme systems, including oxidative phosphorylation and ATP production. It is also necessary for the structural integrity of DNA, RNA, and ribosomes. In addition, it affects membrane potential, and deficiency can lead to cardiac dysfunction and neuromuscular complication. The other mineral component here is glucose. So glucose intake after a period of starvation suppresses gluconeogenesis through the release of insulin. Excessive administration may therefore lead to hyperglycemia and its sequelae of osmotic diuresis, dehydration, metabolic acidosis, ketoacidosis. Excess glucose also leads to lipogenesis, again as a result of insulin stimulation, which may cause fatty liver, increased carbon dioxide production, hypocapnia, and respiratory failure. Vitamin deficiency. Although all vitamin deficiency may occur at variable rates with inadequate intake, thiamine is of most importance in complications of refeeding. Thiamine is an essential coenzyme in carbohydrate metabolism. Its deficiency results in Wernicke encephalopathy, that is, ocular abnormalities, ataxia, confusional state, hypotemia, coma, or Korsakoff syndromes, which is known as retrograde and anterograde apnea confabulation. And the last group of mineral here, which we have to talk about, is sodium, nitrogen, and fluid. So changes in carbohydrate metabolism have a profound effect on sodium and water balance. The introduction of carbohydrate to a diet leads to a rapid decrease in renal excretion of sodium and water. If fluid repletion is then instituted to maintain a normal urine output, patients may rapidly develop fluid overload. This can lead to congestion, cardiac failure, pulmonary edema, and cardiac arrhythmia. So we now ask this other question, which is how can refeeding syndrome be prevented? This one is very important. So essentially, patients may be malnourished as a result of reduced intake, for example, owing to dysphagia, anorexia nervosa, depression, alcoholism. Reduced absorption of nutrition, as in, for example, inflammatory bowel disease, celiac disease, or increased metabolic demands, for example, in cancer surgery. High-risk patients include those who have been chronically undernourished, especially those who also have diminished physiological reserve. Patients with dysphagia, for example, as a result of stroke, in particular, may be at high risk. So I will give now a list of this patient kind of detailed here. So patient at high risk of refeeding syndrome, you have patient with anorexia nervosa, patient with chronic alcoholism, oncology patients, post-operative patients, elderly patients, that is those with comorbidities, decreased physiological reserve, patients with uncontrolled diabetes. This point is very important here, as I've been saying time and again. For those of you having diabetes, that you need to be very careful here. Eat properly and also do the exercise as I've always advised. So we have electrolyte depletion here. Diuresis is also another thing. Patients with chronic malnutrition like marasma, prolonged fasting or low energy diet, morbid obesity with profound weight loss, high stress patient unfed for more than 7 days. And so that's the key thing here. And another key point here, it is criteria for the guidelines of National Institute for Health and Clinical Excellence for identifying patients at high risk of refeeding problems. So we have either the patient has one or more of the following. So listen carefully here. Body mass index less than 16 is already a red flag. Unintentional weight loss more than 15% in the past 3 to 6 months is a red flag. Little or no nutritional intake for more than 10 days is a red flag. Low levels of potassium, phosphate, or magnesium before feeding. Or the patient has 2 or more of the following: body mass index of less than 18.5, unintentional weight loss greater than 10% in the past 3 to 6 months, little or no nutritional intake for greater than 5 days, history of alcohol misuse or drug including insulin, chemotherapy, and NSAIDs or diuretics. So that one also is another key thing that you have to take into consideration. The next question is, how can refeeding syndrome be detected and treated? This point is very important. Refeeding syndrome is detected by considering the possibility of its existence and by using the simple biochemical investigations described above. If the symptom is detected, the rate of feeding should be slowed down and essential electrolytes should be replenished. The hospital specialist detects dietetics team should be involved. So it is not just you, a layman, looking at things, but you also need to bring in some expert from the hospital, to the dietitians. The team has to be part of it in order to make things go smoothly for the patient. And then in conclusion, adherence to NICE guidelines for preventing and treating refeeding syndrome should reduce the incidence and associated complication of the syndrome. So that's what I would say. And now just to re-summarize what I've said above is, refeeding syndrome is a potential fatal condition caused by rapid initiation of refeeding after a period of undernutrition. It is characterized by hypophosphatemia associated with fluid and electrolyte shifts and metabolic and clinical complications. Awareness of refeeding syndrome and identification of patients at risk is crucial, as the condition is preventable and metabolic complications are avoidable. Patients at high risk include chronically undernourished patients and those who have had little or no energy intake for more than 10 days. So you can imagine someone leaving the hospital, going back home, and you just put him right away with Khati-khati. I don't think that's the right thing. Or give the person fufu and arrow. These are all food that I call them solid food, that digestion is actually slow. So I will recommend you not to put them on such solid food, but it should be liquid food. And I will tell you further how to prepare those liquid food. Refeeding should be started at low level of energy replacement. Vitamin supplementation should also be started with refeeding and continue for at least 10 days. So you need to make sure that for this transitional period, or what we say patient is in convalescence, you need to make sure that it should be liquid meal for this time in order for the patient to adapt back to his or her environment. Correction of electrolyte and fluid imbalances before feeding is not necessary. It should be done alongside feeding. So essentially, that's the whole thing here. I know we are blessed with beautiful food, delicious meal, and we are anxious to see our loved one coming back home to meet us. But again, we risk killing them unknowingly. That's why I'm making this lecture, for you to understand properly. Say, for instance, your grandpa or grandma is lying in the hospital and they move back home. You don't need to give him or her solid food. It should be liquid first for the first 10 days. Then now gradually you can now introduce your best diet, call it your fufu and arrow or corn chaff or whatever thing you want to do. That should be fine. Otherwise, you risk putting past life in danger. Thank you so much for following up my lecture. My name is Dr. WAN, and have a wonderful evening. Do not forget to subscribe for more video. Thank you and bye-bye.